Good morning, respected doctors. I'm Yogesh Tambadkar from Imker Pharmaceuticals. I welcome you all for this webinar series organized by Dr. M.B. Agarwal sir under Mumbai Hematology Group. And at MQR, we are committed to collaborate with clinicians and provide them the platform for scientific discussion and latest updates in patient care. So we are indeed grateful for Dr. M.B. Agarwal sir for giving us this opportunity to be a part of this scientific fest. And I'm really honored to invite sir for today's webinar. Sir doesn't need an introduction. He's the president of Mumbai Hematology Group, and he's currently professor and head of department at Mumbai Hospital. And sir has more than 30 years of experience in hematology. So sir, without any further delay, I hand over this session to you, sir, and for further proceedings. Thank you, sir. Thank you for giving us opportunity.
Thanks, Mr. Yogesh. Good morning to one and all. Today, our guest speaker is Professor Dr. Nita Radhakrishnan from Noida. She will be lecturing on multiple facets of megaloblastic anemia. This webinar is brought to you by Mumbai Hematology Group, supported by MCure and managed by Perfect Square. I thank Mr. Keyur Soni and the team from MCure, Mr. Yash Kalpesh and the team from Perfect Square, Executive Committee of Mumbai Hematology Group. Our chief guest today, Professor Dr. Deepak Bansal from Chandigarh. Our guest speaker, Professor Dr. Nita Radhakrishnan from Noida. All our discussants who are themselves eminent hematologists or pediatric hematologists, new participants for sparing your Sunday morning, afternoon, or evening, depending upon which part of the world you belong to. This is our website, www.mhgindia.com. You can look at all our future academic activities at this site. It is open, you don't require any code. You can also visit a number of presentations that have been put there in case you have missed some, and if you have had the permission to put it on the website, they're all there and you can do this at your leisure time. Next weekend, Saturday evening, 7 p.m. IST, Dr. David Kutter from Massachusetts will be speaking to us on the pathophysiology of ITP and novel therapies. And the next day, that is Sunday morning, 21st of August at 11:30 IST, Professor Ashutosh Vachlekar from University College London will be speaking to us on certain aspects of AL amyloidosis, what's new. By now, you know that the midterm conference of Mumbai Hematology Group, which is a live conference, in-person, physical meeting for the first time after 2.5 years. MHG is doing this event in Bombay Hospital, whole of Saturday and Sunday, 3rd or 4th of September. The whole agenda is put up at the website. If you have a look at it, it is very exciting with 40 faculty. September is a lymphoma month. 15th September is Lymphoma Awareness Day. And Mumbai Hematology Group brings this elaborate webinar to you on lymphomas, the challenges in managing lymphomas in 2022, with 15 international guest speakers from USA and Europe, from 6:25 p.m. to 9:30 p.m., 3 lectures a day for these 5 days. And this will cover everything that you should know and what has happened with respect to advances in the field of lymphoma. So if you can spare your evenings, this is a wonderful opportunity to go through everything in lymphoma. Our discussants today have been put up here in alphabetical order. They are very important personalities. Dr. Gunjan Prasad from Apollo Hospital, Kolkata. Dr. Radhika KK from Nizam's, Hyderabad. Dr. Ketan Nathani from KM Hospital, Mumbai. Dr. Krishnaratnam Kannan from Ramachandra Medical Center, Chennai. Dr. Omkar Khanka from TN Medical College, Bombay Hospital, Mumbai. Dr. Purva Kanvinde from Vijayawada Hospital for Children, Mumbai. Dr. Rintu Sharma from Dayanand Medical College and Hospital, Ludhiana. Brigadier Dr. Sanjeevan Sharma from Command Hospital, Lucknow. Dr. Satish Kumar from Manipal Hospital, Bangalore. Dr. Shailendra Prasad Verma from King George's Medical University, Lucknow. It's time to introduce our special guest for the day, and we are indebted to him for sparing his time and agreeing to inaugurate our webinar and give some words of wisdom. And that is Professor Dr. Deepak Bansal. Everyone knows him, but I have to complete the formalities. He's Professor, Hemato-Oncology Unit, Department of Pediatrics, Advanced Pediatric Center at the prestigious PGI Chandigarh. He's faculty member, PHO Unit, PGI Chandigarh, running DM in Pediatric Hemato-Oncology from 2009. He is MD, DNB, FA, MS, FI, AP, Clinical Fellowship, Pediatric Hemato-Oncology, Canada. He's Editor-in-Chief, Pediatric Hematology Oncology Journal. He's past Secretary of PHO Chapter of IAP. He's Section Editor of Indian Journal of Pediatrics. The recipient of Dr. I.C. Verma Award for Excellence in Research. Also recipient of Dr. P. N. Raju Oration and Dr. H.B. Dingley Memorial Award by ICMR. It's published peer-reviewed 280 papers with H index of 27. We are indeed fortunate to have him this morning, and I request him to inaugurate our webinar and give some words of wisdom to our students, fellows, trainees, and even others. Over to you, Dr. Bansal.
Thank you, sir, for that very kind introduction. Am I audible?
You are audible.
Right, thank you. Sir, I mean, I'm not so used to giving this words of wisdom, but I have tried to put up some few points, which I'll just sort of say in the next few minutes. So the first question is, why to take up pediatric or generally hematology oncology? So I think the answer is fairly clear-cut in everybody's mind. It's basically because we want to treat challenging cases. You know, we like to deal with life and death decisions. When we join pediatrics or internal medicine, one has several specialties to choose from, but then one has to ask oneself that, you know, one's personality is to work in something like radiology or dermatology, or whether one really wants to work in oncology. You know, that answer would come from within. So I was always interested in pharmacology and therapeutics, and that's one has plenty in pediatric hematology oncology. There is always a thrill in treating cancers, and that is hard to obtain in other specialties. So I would just like to talk about what qualities are helpful while being a hematologist, oncologist. I think the foremost is that one has to be a team player. One has to try to act like the member of a choir and not try to be the lead singer each and every time. We deal with several cancers like retinoblastoma, bone tumors, Wilms, neuroblastoma, and brain tumors, wherein we have to work 1:1 with ophthalmologists, orthopedicians, pediatric surgeons, neurosurgeons. We have to work with very close cooperation with the lab hematologist, histopathologist, radiologist, and not to forget our radiotherapy colleagues. So being a team player is extremely important. Any hemonc unit must be having a running tumor board, because that's a sign of a mature and a democratic program. And I think we should all agree to disagree, but continue to move ahead. I remember a few years ago, I had asked a pediatrician from the interiors of Punjab that what are the typical qualities of a pediatrician who works in the grassroots? And his answer was very straightforward, that one needs A, B, C. I think these are fairly popular. A refers to availability, B to behavior, and C to competence. So before competence, it's the availability and behavior, which are really important, which continue to be important in all specialties. Then one has to be a good communicator and a counselor. So I worked in CMC Vellore for a few months about 25 years ago in 1997. And I remember Dr. Maman Chandy and Dr. Alok Srivastava being able to switch between languages. They knew multiple languages, I think at least 5 or 6, English, Hindi, Tamil, Telugu, Malayalam. And it was really nice to see them talking to patients in their own mother tongue. Counseling, I think, has to be very clear-cut, and message should be provided to the family. Whether one is giving palliative care or curative, it should be very clear-cut, said in words. I think in India, it is good to counsel the entire family and even the extended family, because otherwise they would be coming separately and asking. And the thing which we often miss is we should encourage the older children to be included in the counseling as well, because that helps really to improve the compliance and adherence to treatment. So the other topic that I would like to talk about is employment. So there is a concern that probably there are too many PHO fellowships ongoing, and that's good for the busy units because the residents are provided kind of as labor. But what about the jobs? I think it's a problem because most of us like to settle in the metros, but thankfully now we have increasing aims like institutions and other government medical colleges, but then one will have to do general pediatrics as well as PHO. So one has to be willing for that. Data centers are coming up in Varanasi, Visakhapatnam. So one needs to have flexibility to work in tier 2 cities and take up either corporate, government, or trust hospital jobs. We always pride ourselves in saying that we get patients from far off places like UP, Bihar, West Bengal. So it's always good to go there and rather work in those states. There is always this question about bone marrow transplant, whether I should be doing or not. It's the attractive and the glamorous component of hematology oncology. So I did this 2 years BMT training in Canada, but still have not been an active allogenic transplanter as yet. So one may not get everything when one starts practicing. But hopefully we will soon get a pediatric BMT unit. So, I kind of got sunk into the non-BMT hematology oncology. So one has to adapt and keep on looking for the future. So we are always asked, should I do a BMT fellowship after PHO training? And I think it depends on a lot of circumstances of family, marriage, kids, and responsibility of parents. So while I was leaving CMC Vellore, Dr. Alok told me that one has to marry hematology. And Dr. Maman said there are no shortcuts to success, particularly in hematology oncology. So the other challenging aspect of hemonc is that one has to be a student throughout life. During my own career, I have seen the treatment of neuroblastoma, pediatric ALL, APML, Hodgkin's change. So one just cannot be rigid and one has to be willing to change. Most of us are jack of all trades and masters of none. We like to do benign, malignant, hemat, solid tumors, and bone marrow transplant. And that's because of the dynamics of faculty and doctor-patient ratio in our country. But still, one should try to develop 1 or 2 areas of expertise. And there are still some areas like neuro-oncology, coagulation, sickle cell anemia, and BMT for immunodeficiencies, which still need more people. So one has to have the flexibility to adapt, as well as the willingness to give away a few diseases to concentrate on the rest. So one should also be adapted to patient resources, and one should be willing to scale down the diagnostics as well as treatment if the patient is not affordable. So we learn new things, but one has to be able to be adapted to the patient's resources. So from this, I would like to remember my mentor, Dr. Marwaha, who always told me that either patient's richness or his poverty should not be considered as a limitation to his treatment, and one should be able to mold oneself to be able to treat him. I would also like to talk about the PowerPoint presentations that one is often asked to do. And about 20 years ago, I heard Dr. M.B. Agarwal talk on iron deficiency anemia. And the thing which I learned from it was his trademark one-liner sentences on the slides And from then onwards, I resolved to make similar slides with very limited material so that one is able to communicate what one really wants to say and not to load each slide with too much of material. So Hemonc is a time demanding specialty. One needs passion, one needs support from the family. One would keep on seeing patients with relapses unexpectedly, reminding us that we are dealing with oncology. One would often be perennially dissatisfied and feeling that one is not doing enough. And you attend one international conference and come back depressed, thinking that one is so far behind. But at least I'm extremely happy and contented that one is able to care for one's people, and in one's own environment and continuing to grow. Just to end, I think it takes long to build a hematologist oncologist, and we need to take care of our own health. And one has to avoid falling prey to addictions along the long route of training. One should try not to use food as an award at the end of the day, eat healthy and exercise. When Barack Obama can exercise daily for 45 minutes, even during his presidency, we should not think that we are that busy. So we all need to live long, healthy lives to look after our families and patients in the highly fulfilling and satisfying specialty of hematology oncology. Thank you so much, Dr. M.B. Agarwal, for giving this opportunity. Thank you.
Thank you, Professor Bansal, for those wonderful messages. Your brief speech had so many messages, beautifully crafted. You have planned the whole speech very well, and I think the listeners must have benefited in a very big way. And thank you so much for sparing your time, agreeing to be with us this morning. It was very, very useful. Move on to the second segment of this morning webinar, and that is today's quiz and the today's case. So as usual, we'll have the Sunday quiz, and you'll be sending your answer to this email, which is put at the top, mbagarwal1@gmail.com. Today's quiz is related to Gaucher disease type 1. You'll be shown 10 statements. One of the statement is false. And you have to email the number of that false statement, 1, 2, 3, whatever that number is, to mbagarwal1@gmail.com. Fastest finger first will be the winner, and we will be telling you the names of all those who send the correct answer in the order in which we receive the reply. Here are the 10 statements related to Gaucher disease type 1. 1. Gaucher disease is the most common lysosomal storage disease. 2. The type 1 GD is the most common form of presentation. 3. Type 1 is non-neuropathic type. It presents with spleno-hepatomegaly, anemia, thrombocytopenia, bleeding tendency, or skeletal disease, often in combination. 4. Gaucher cell is a pathognomonic finding in Gaucher disease. 5. Patients often have hyperferritinemia, monoclonal gammopathy, and increased NK and NKT cells. 6. There's a long-term risk of B cell and plasma cell malignancies, that is lymphoma and multiple myeloma. 7. Treatment is intravenous enzyme replacement therapy or oral substrate reduction therapy. 8. Bone marrow transplantation has been largely superseded by ERT or SRT. 9. Splenectomy should be avoided in GD. And 10. There is some association between GD and Parkinsonism. So one of this statement is wrong. 9 are correct. Whichever is the wrong statement, the number of that is to be emailed. I'll keep this on for a few seconds. Okay. So one of the statement is wrong. Email the number to mbagarwal1@gmail.com. Winner will be the fastest finger first. After we have the guest lecture, and before we go to the Q&A session, we will tell you the correct answer, the winner's name, and names of all those who send in the correct entry. The last part before the formal lecture is the case of the week. This is a 41-year-old man who came from Indore. He was referred for Evans syndrome, that is autoimmune hemolytic anemia with ITP, which was refractory to the various modalities of treatment he received. He was unwell for last 7 months, during which he had intermittent low-grade fever, significant anemia needing blood transfusion support repeatedly, icteric, he had skin and gum bleeding off and on. There was no history of loss of weight, night sweats, or pruritus. There was nothing to suggest involvement of any other part of the body. There was no relevant past or family history. His workup in Indore had confirmed that there was classical direct Coombs test positive autoimmune hemolytic anemia and ITP, with bone marrow showing consistent changes with this diagnosis. His antinuclear antibody test was positive in significant titer. However, there were no other clinical features of SLE except the Evans syndrome. The modalities of treatment he had received and completed included steroids, IV gamma globulin, dapsone, azathioprine, and cyclosporine. There wasn't any significant response. His examination showed significant multiple massive cervical and axillary lymphadenopathy, together with hepatosplenomegaly of 4 centimeters each. And this was something which was different than the diagnosis that he was carrying of Evans syndrome. His hemoglobin was pretty low, platelet count was very low. He had a normal total and differential WBC count. Evidence of hemolysis with direct Coombs test positivity was reconfirmed, and the ANA positivity was also reconfirmed. The anti-double-stranded DNA was negative. His lymphadenopathy in neck, axillae, and groin was really massive. CECT showed similarly large lymph nodes in the chest, abdomen, and pelvis. Workup for various infections like HIV, TORCH, EB virus, parvovirus, negative. A repeat bone marrow trophine biopsy showed no evidence of lymphoma. Right axillary lymph node biopsy was done. It showed florid follicular hyperplasia, focal progressive transformation of germinal centers, marked paracortical hyperplasia, expanded interfollicular areas populated with T lymphocytes. There was a polyclonal plasmacytosis, and once again, there was no evidence of lymphoma, no evidence of granuloma. AFP and fungal stains were negative. This is a picture of his right axilla, showing a massive lymphadenopathy, and this is the biopsy scar. What did the lymph node biopsy show has been described to you, and these are some of the pictures showing florid follicular hyperplasia. And this follicular hyperplasia is made up of small, mature appearing lymphocytes. What you see in the form of arrowheads is highly proliferative paracortical lymphocytes. And then with the arrows, what you're seeing are the immunoblasts. And then what is circled is the plasma cells. There was sinus histiocytosis with phagocytosed lymphocytes as seen by the arrowheads. A diagnostic test was done. This diagnostic test was peripheral blood flow cytometry. It showed 8% lymphocytes to be double negative T lymphocytes, CD3 positive, CD4 negative, CD8 negative. And these cells were positive for alpha beta T cell receptor. This combination is classical of ALPS. So a diagnosis of adult ALPS, that is autoimmune lymphoproliferative syndrome, was made. Plasma soluble IL-10 was increased to 36 with the normal being up to 20. S vitamin B12, which is characteristically very high in ALPS, was not high in this patient. The flow cytometry, what you see in A and B is the expanded population of T lymphocytes. And these T lymphocytes were positive for CD3 and they were negative for CD4 and CD8. And they showed the characteristic alpha beta T cell receptor and negative for the gamma delta. NGS panel, interestingly, did not show any mutation in FAS ligand, or CASP10. As he had not responded to steroids, steroids were tapered and treated with sirolimus and MMF. An excellent response, and after 2 months, there was a complete control of hemolysis and ITP. The lymph nodes and the hepatosplenomegaly almost totally regressed, including on imaging. In fact, he could be taken off the treatment. Now he's off treatment for a year with a close follow-up, and there has been no relapse. A little bit of literature on this subject, that is ALPS. Now, there are a lot of autoimmune and autoinflammatory diseases. ALPS is on the extreme side with a monogenic autoimmune disease. Classically, it is an inherited disease. And on the right side, you see the rare monogenic autoinflammatory diseases and all others in between. Lymphoproliferation could be autoimmune, infection, or malignancy. The one on the left being the rare one, and the one on the middle and the right being the common ones. When you have hemolytic anemia, the two classical way to differentiate is the one which is immune mediated and the one which is not immune mediated. And the one we had was the one shown on the left side, the immune mediated. Now, this is the pathogenesis of ALPS. What you have exactly is the apoptosis single receptor. That's the full name for the FAS pathway, which is usually involved in apoptosis. So you could have a mutation in the FAS or FAS ligand, as a result of which apoptosis is not taking place. Another mutation could be in the caspase-10. So these are the three classical mutations, FAS, FAS-L, or caspase-10, which lead to failure of apoptosis, leading to lymphoproliferation. In 2010, the diagnostic criteria of ALPS were revised. And what you see at the top is something which is most important, a chronic, that is more than 6 months, non-malignant, non-infectious lymphoproliferation in the form of lymphadenopathy or splenomegaly or both. And then the increase of CD3 positive T cell receptor of alpha beta positivity with negativity for CD4 and CD8, so double negative lymphocytes, accounting for more than 1.5% of total lymphocytes or 2.5% of CD3 lymphocytes in the setting of normal or elevated lymphocyte count. And then there are accessory criteria which relate to documenting defective lymphocyte apoptosis by 2 separate assays. And at least this test is not available in Mumbai and probably may not be available except in some very major immune centers in this country. And one what is available through the standalone labs today is looking at the somatic or germline pathogenic mutation in FAS ligand or the CASP10. Then there are the secondary criteria which relate to elevated plasma soluble FAS ligand level, interleukin 10, B12, interleukin 18. the typical immunohistochemistry on the lymph nodes or the splenic biopsy or the splenic aspirate, autoimmune hemolytic anemia, thrombocytopenia, neutropenia, polyclonal increase in immunoglobulins, and sometimes the family history. Though this is an autosomal dominant disease, the penetrance is variable very often. Despite that, there may not be a family history at all. And depending upon the type of mutation, it is called ALPS FAS, FAS mutation germline, ALPS S-FAS, FAS mutation somatic, ALPS FAS-L, where there is a FAS ligand mutation, ALPS CASP10, where there is germline CASP10 mutation. And if all of these are not there, which happens in 30% of patients, as in our patient, then you call it ALPS U. So our patient fits in ALPS U. This is sort of elaboration of what I just showed you, how one goes in practice. What is most important, just this part, no. So if you do not have chronic non-malignant lymphoproliferation, or you do not have increase in double negative T cells, or you do not have these biomarkers, then think of an alternative diagnosis. And that's the treatment. Steroid is, of course, the first line of therapy. Its failure or intolerance takes you further to MMF or sirolimus, which are the two most powerful agents. And you can get rid of the steroids with the use of these. And then in refractory cases, other methods. Learning point from this case to me and to you and to everybody is that though it's a disease which presents in adolescents at the median age of 11 years, and the disease manifestation can start in the first year of life, the adult ALPS is not a totally unknown disease. Overall, of course, it's a rare disease, even in pediatric practice, but it is not something which does not happen. So at any age, you should think of ALPS. Whenever you have a combination of autoimmune problem in hematology together with lymphoproliferation, and which is not lymphoma, which is not infectious, think of this. Look for the detecting the DNT, the double negative T lymphocytes, and that will clinch the diagnosis, and the cells will be positive for alpha beta T cell receptor. Similarly, you can ask the histopathologist to look for this in the lymph node by IHC. And lastly, you can look for the mutations, but they can be absent in 30% of cases. Once diagnosed, those steroids work. You can use steroid sparing sirolimus and MMF. Because there is a higher incidence of lymphoma, which is for the rest of the life, you should follow up these patients throughout. And bone marrow transplant is indicated only if there is a failure of immunosuppressive treatment and if patient is significantly affected. Well, we now go to the main part of the webinar today, and that is our inviting our guest speaker, Professor Dr. Nita Radhakrishnan, to speak to us on megaloblastic anemia. And it's my privilege to introduce her. She's Associate Professor and HOD, Department of Pediatric Hematology Oncology at Postgraduate Institute of Child Health, Noida. And now she'll speak to us on this subject.
Good morning, everybody. Is my audio clear?
Yes.
Thank you, sir. Before I start, I would like to thank the Mumbai Hematology Group and Professor M.B. Agarwal for this opportunity. This is a topic, like we were just discussing before the session started today, that this is a disease which has been there for so many years and there's so much history around it. And it's highly humbling to talk about it in a group of very senior hematologists. So I hope I do some justice to the topic. So I work in a pediatric institute, and almost all of my experience is pediatric based, and that is what I'm going to be sharing today. So this disease, like many other diseases in the history of medicine, has so much of history behind it. And whatever we learn today is because of the effort and the lot of hard work has gone by in centuries of medicine, and that's what we are dealing with today. So how did it all start? This disease was somehow described very, very early in the 19th century. And among all the nutritional anemias, I think this has got the most glamour because of the very fact that this affected a lot of, for me, I think it is because of the fact that it affected a lot of the developing world, the developed world. So a lot of people in the lot of Caucasian population was affected with pernicious anemia, and that was described as early as the 19th century. And it was described even in case reports by Sir William Osler. And later, when Ehrlich and Wiegert started staining slides, they also described that there are cells which are larger in size. So those were the earliest report of these megaloblasts. And then it was termed megaloblast by Zadig. And later, hypersegmented neutrophils was described by Nagelli. The spinal cord involvement, that is the subacute combined degeneration, which has been described along with pernicious anemia, was for the first time described by Lichtenstein. And later, Whipple, Minot, and Murphy, these three individual scientists described how it can be treated. So earlier, in those days, they did not know what it was due to. So they used to do venesection of dogs to make the dog anemic. And then they used to feed different combinations of drugs and medicines and food items to see what worked. And in one of those experiments, a liver extract worked, and it found that the dogs which were fed on this liver extract actually improved. And that went on to make liver extract as a predominant treatment for so many years after that. So this is a prescription from those times where liver, half a pound of liver is actually given as a prescription for these patients who had pernicious anemia. And this work, and it was not just liver, it was highly unpalatable. And along with liver, there was egg, there was some green leafy vegetables as well as milk. And this diet had to be continued daily for 2 to 4 years for the response to be documented and cure to be documented. So this treatment, although it sounded very gross, it sounds very gross now, it was at that time, it was a fatal disease, pernicious anemia, and that this disease could be treated by this concoction. And that's how this triad of scientists, they got the Nobel Prize for Physiology and Medicine. So it does not end there. Subsequently, many other scientists were involved for the next 2 decades to find out what was in that liver extract which was actually working. And then finally, they isolated the B complex and the B12 as a, the isolation happened in 1940s parallelly in the US and UK. And later, the crystal structure of it was found by Madam Dorothy Hodgkin. And she did it after around 10 million calculations to find out. And so that is that the red crystal, which is there in the picture, was found after so much of hard work. And she deserved a Nobel, nothing less than a Nobel Prize for this work as well. And incidentally, she had also had work on penicillin and insulin. She was the person who described these structures as well. So the Nobel Prize was not just for B12, it was for the other molecules as well. So megaloblastic anemia is this heterogeneous group of anemias. It's not a single deficiency, or it's not a single etiology. All of them have a common entity, which is megaloblast. And megaloblasts are these large precursor red cells in bone marrow as well as in blood. And it's a misnomer to some extent, because if you just describe it as anemia, in this case, it's not just anemia. Unlike in iron deficiency anemia, essentially only red cell series are affected. But here, all 3 cell lines are involved. So it's not just anemia, one. And second, it's not just hematopoietic system that is involved. There are other organ systems like neurology, liver, a lot of other organ systems are involved parallelly. But still, we use the same terminology, which was described so many decades ago. Now we know that either it could be B12 deficiency or folate deficiency at the cellular level, which is causing this. And basically what it causes is a nuclear cytoplasmic asynchrony, because of which there is a delay in the maturation of the nucleus. And that's why you have these large cells with large nuclei. And hematological manifestations in both these diseases, both these deficiencies are similar, but neurological manifestations are different. And neurological manifestations we essentially see in B12 deficiency predominantly. So we'll see a few case scenarios as to how this entity called megaloblastic anemia presents to us. So this is a very straightforward 10-month-old girl who is presented with irritability and poor feeding. The CBC is diagnostic. You have a hemoglobin of 2 on an MCV of 109. There is some neutropenia. Platelets in this case is normal. And this is a usual, and many a times you don't need to go further. This is a usual scenario where it's a late second half of infancy, a baby who's either being breastfed long for prolonged breastfeeding, not started on complementary feeding, mother deficient. So that kind of scenario. And in most of these children, just a therapeutic trial is enough, and you get to the diagnosis retrospectively after you treat and the response happens. Another very common scenario is an adolescent girl. An adolescent girl in this case was referred from gastroenterology. The child actually went there with complaints of not eating well, vomiting, and pain abdomen. And when they saw the child was, other than pallor, there was icterus as well, and there was hepatosplenomegaly. So they evaluated for the usual viral hepatitis. And on evaluation, a CBC showed a hemoglobin of 8 with MCV of 110. Platelets were slightly low. And in the bilirubin, there was unconjugated hyperbilirubinemia, and that prompted them anemia with an unconjugated hyper will with a splenomegaly, made them suspect hemolytic anemia and refer. And here again, with this high MCV, a retic count would help in this scenario and a peripheral smear, and that's all that we did and proceeded to. This was again diagnosed as megaloblastic anemia based on the peripheral smear, and treatment was started. This is a third child, a third scenario, again an infant who was presented with pallor. This time the parent has noticed the pallor only since the last 2 days. There is reduced feeding, and there was some impetigo on the tip of the nose, side of the nose, which started bleeding, and these prompted the family to come to the hospital. And when we see the child is not growing well, 6.5 kilos with severe pallor, and these abnormal movements can be noted. So there is this listlessness which is there, the baby is not too active. On top of that, there are these movements, these abnormal tremulous movements which are seen. And when we look at a CBC, here again, hemoglobin is very low, 1.6 hemoglobin with an MCV of 106. Peripheral WBC count was 3,400 with neutrophil count being low, platelets again low. And here peripheral smear was also suggested, as well we got a vitamin B12 level because of this neurological involvement, and that was low, and that everything corroborated to an infantile presentation with an infantile tremor syndrome kind of presentation of vitamin B12 deficiency. She was treated for the same and she improved. Another scenario is a 12-year-old girl. Now, again, she has presented with another neurological manifestation. She has presented with a 2-day history of paucity of movements of right upper and lower limbs. And she's come with slurred speech. So it's essentially only a pure neurological involvement. But somehow, because of the pallor, she got this paucity was not very severe. And so the father just said, since 2 days, she's not moving her arm well. So the pallor got noticed and she was admitted under us directly. So hemoglobin was 5 here, and there was nothing else clinically, just for a small spleen and right-sided hemiparesis, which was noted on UMN type of hemiparesis, which was noted on CNS exam. So hemoglobin was 5.2 here, again MCV high, WBC count okay, platelets normal. Homocysteine was done. So here, because of this high MCV anemia, so one of the suspicion was whether this is megaloblastic anemia causing thrombosis. It could be an arterial stroke, it could be venous thrombosis. So here the clinical features were suggestive of an arterial involvement, whether there is an MCA infarct or something. So she was started on treatment parallelly, and an MRI was scheduled. The MR happened around 3-4 days later because there was some issue in finances. And by the time they got the MR, there was nothing really significant. There were some gliotic changes which were shown in the BCI category. She improved beautifully within just 24 to 48 hours. That complete weakness resolved with management of the deficiency. Homocysteine level was elevated in this case. Another scenario. So here, this is a 13-year-old girl. So this child is a little sicker than what we saw till now. She's been brought to emergency with giddiness, severe pallor. She's come with cardiac failure and hypotension. And there is severe pallor, icterus, no organomegaly. She was stabilized in the casualty. She was started on transfusion as well as inotropes. On examination, her there was nothing significant except for some edema, icterus, pallor, and there is no organomegaly at all. So hemoglobin was 2, MCV again high, WBC count platelets, WBC count was normal, platelets were a bit low, peripheral smear very, very classical of megaloblastic anemia. Here, the confounding factors were that there is icterus and the jaundice was quite unusual for what we see in megaloblastic anemia. Your bilirubin is 9.4 with a direct component of 3.7. SGOT, SGPT were raised, 1,281 SGOT. And if you look at the albumin is 2.6. So although we see a little bit of hypoalbuminemia in many adolescent girls who come, they have what is classically described as that sallow complexion. There's a little bit of periorbital edema, arms, and even in small babies, you find that little puffy looking children. This degree of hypoalbuminemia is usually not encountered. And here again, there's this hypoalbuminemia was symptomatic. It was causing both ascites as well as pericardial effusion. She was again, after this initial transfusion, her rhinotropes were weaned off and she was just managed with parenteral B12 and folic acid was also given here. And she improved only with this. And in the next, I have a graph of her weight gain as well. So she just improved with B12 folic acid and there was the liver function completely improved and has stabilized, and it's now around 3 months since this presentation in April, and she is well and does not have any underlying liver dysfunction. Another presentation, this is a 17-year-old girl. She has presented with severe pain in the left leg. So the pain prompted them to go to orthopedics. From orthopedics, there was nothing which was there in the bone as such. So she was referred to pediatrics. And from pediatrics, a Doppler was advised, which showed DVT of the left popliteal vein. And from there, she was combined consult with CTVS as well as our department was made for starting anticoagulation for a possible idiopathic DVT because she is otherwise well. Peripheral smear was just showed megaloblastic anemia here as well. There is no family history, nothing to suggest an inherited thrombotic condition, a prothrombotic state. And so she again, although she was started on low molecular weight heparin once a day because her platelets were, I think platelets were okay. She was started on B12 and within 24 to 48 hours, even with anticoagulation also the pain improved and she was taken off anticoagulation. She's just continued on B12 currently. Another child, an 18-year-old boy. So this is just increasing the complexity. So he is the fourth child of non-consanguineously married couple. Others 3 siblings are healthy. And this kid is now 18 years. He is presented at 7 years of age with severe pallor. And since then, he has a very big file and he has gone to multiple hospitals. Every time he goes in with pancytopenia, receives multiple transfusions. At times, there are prescriptions for B12 and folic acid, which also has been given. But somehow the family has also not been very regular. And this is our third visit. So this child recently came again around a month back. So this is our third consult with, they've consulted us for the 3rd time. So every time in the past as well, whenever we advise something, it's given for a few months and then stopped. So he has a very classical history that at 14 years, he had some difficulty in vision for which he was taken to an eye center. And there he was diagnosed to have subluxation of lens. Both eyes underwent IOL was implanted in both eyes a year apart. And currently he does not have any visual involvement. There is developmental delay. The parents have stopped sending him to school because he's not too bright. And on examination, he has some marfanoid habitus. And on clinical exam, other than this, there's nothing significant, no organomegaly and no skin changes, nothing like that. The CBC again is very characteristic pancytopenia with macrocytosis and homocysteine level is quite high. So this again, this child was worked up. For subsequently, we'll see how the workup happened. And this child, since there are recurrent episodes, we're looking at a cause which is not nutritional per se and no real malabsorption because of the involvement of other factors like a genetic etiology is being looked into. And finally, a 10-year-old girl, she has Down syndrome and she has been failing to thrive developmentally, the usual Down baby. Presented almost, I think 8 months ago with pain abdomen, breathlessness and fatigue, 3 PRBC transfusion in 5 months prior to the presentation, severe pallor, tachycardia with a flow murmur and low blood pressure. She was managed initially with transfusions. But if you look at the initial workup, uric acid came, the TLC also. So the CBC showed a hemoglobin of 7 with MCV of 110. So down, we know down per se can have macrocytosis. So we looked at the smear to see whether it was just macrocytosis or whether there is megaloblastic picture associated. Here, the WBC count was high. So a down baby presenting with again, some bit of cytopenia is expected, but if there is significant cytopenia requiring transfusions, a child presenting with this kind of picture, we would definitely look for malignancy as well. So KFT uric acid was sent, and that showed a uric acid of 13 milligrams. LDH was very, very high. So all the more reason to evaluate for an underlying malignancy as well. The smear did not show us any evidence of malignancy per se, only hypersegmented neutrophils and some NRBCs were seen. That's probably why the WBC count is a little, there's one more reason why the WBC count is high. And bone marrow did not show us any blasts as such, although there was fibrosis which was seen in the marrow. So this entity, this hyperuricemia presenting in a child with no malignancy, only megaloblastosis, although it has been described earlier, it's very rare. So high LDH, there is destruction of the tissue that is happening, destruction of cells that are happening in megaloblastosis because of ineffective erythropoiesis, but that causing high uric acid, and that is a little unusual. And she was managed with allopurinol. Hydration was a bit difficult because she came in with cardiac failure and hypotension. So to increase fluids were difficult. She was just managed with B12, folic acid, and allopurinol. And one of the complications that we see in severely megaloblastic children when we treat is hypokalemia, that is potassium dropping when you add B12, and that was seen in her as well. It was anticipated, and it was when it started dropping, it was treated and supported, and she's subsequently well. She's gained weight. The neurological part, of course, a little bit of improvement is there from that. She's able to stand and walk and all now, but the rest, the anemia part has been settled subsequently. So these are the different ways in which megaloblastosis can present to megaloblastic anemia can present to us in pediatric practice. And I'm sure in adult practice, there are most of these scenarios would extend into adult scenario cases as well. So although it has been described, so one of the earliest case reports of megaloblastic anemia came in 1960s in that causing megaloblastic anemia per se in pediatrics. The report has been the last 2 decades have seen a lot more publications that have happened in PubMed, and a lot more. We have become more aware of the fact that this is a deficiency which can be seen. So all of nutritional anemia is not iron deficiency, and there is a subsequent a significant percentage which can be macrocytic or B12 folic acid as well. So these are some publications from India which show that among the percentage of patients who presented with nutritional anemia to them, these are the percentages of patients who had megaloblastic anemia as the diagnosis of nutritional anemia. So you can see even with the same author, there has been a difference in 5 to 6 years. There has been a difference of from 2% to 7%. And some centers, they have reported up to 25% of the nutritional anemias that come to them are megaloblastic. Then again, if you look at what megaloblastic is it B12, is it folate, or is it combined B12 for folate? Again, there is data from our country which shows that B12 is a little more prevalent than folic acid deficiency. And that is among the reports that have come in, and in all ages. It's at all ages, in children, in lactating mothers, in pregnancy. There is a significant proportion, around 20% we can say, that these children have B12 or folate, and among them B12 deficiency should be to the tune of around. Again, why differences are there? Probably because of the way they have the inclusion criteria would be different. The way they are diagnosing B12 or folic acid would be different. So how do these patients present to us? It could be hematological, like we saw in the first few cases. It could be anemia. It could be pancytopenia. There is quite a bit of ineffective erythropoiesis that happens. So these children present with hemolysis. The features similar to hemolysis because of the cell destruction. There would be a little bit of jaundice. There will be hepatosplenomegaly that can come as part of it. There would be LDH, uric acid. These can be also increased, like you see in some hemolytic anemias. So that was this we saw. Then we have presentations of neurological involvement. In neurological involvement, like we saw in the third baby, could be infantile tremors. There could be psychosis. So there are many adolescent children can present with, so they come a little dull. They come not very talkative, not interested in food, that is the usual complaint from the parent. In addition to this, many times when we start treating, there can be, because of neurotransmitter imbalance, there can be exacerbation of these neurological findings. And one of this is psychosis. So I had a kid a couple of years back. After we started treatment, on day 2, day 3, she started, she thought she had some kind of a psychotic feature, and she started blessing others in the ward. So parents were really worried. So whenever we start in extreme megaloblastosis, we should be looking out for these findings. Even if that was not there to start off with, it may come up immediately in the next few days. Also, when we treat such small babies, it is prudent to keep them indoors, because this tremor is going to worsen, potassium can drop. So these kind of things can worsen the clinical scenario. So better to keep them indoors. There could be developmental delay, there could be neuroregression, not just in nutritional anemia per se, but also in many of the genetic features, genetic component as well. Then finally, a miscellaneous aspect, there could be thrombosis, like we saw, it could be arterial or venous thrombosis. There would be skin pigmentation in many of our patients, and there could be some bony morbidity also, it has been described in this. What is the time to diagnosis? So when somebody starts having a deficiency, usually for folate, it is earlier. They come to us within 2 to 3 months of a deficiency, and it's often years for a cobalamin deficiency. So although it is years in an adolescent or an adult practice, in many children, in babies, it may not be years, it could be even months, because your hepatic reserve per se is low, and maternal reserve also would have been low. So infants can present early, but otherwise, if somebody is coming in with a B12 deficiency, it is usually years of B12 nutritional deficiency that has gone in. And why is it important to know? Because whenever we are treating them, and we are ultimately going to stop treatment after a while, so they are going back to the same household, to the same eating patterns. So we need to be really aware of this fact and need to counsel them correctly. Otherwise, we're going to see recurrences commonly. So in my practice, I cater to patients who come from Delhi as well as Western UP. So we see a lot of patients who, after a year, 2 years, come back again with the same problem, because however much you counsel them, and after you stop treatment, they generally, the family reverts to its earlier eating practices. Now, why is this difference? Why is folate coming early and cobalamin coming later? Because if you look at the ratio of the total body store of folate and cobalamin, the ratio of store to RDA is actually lesser for folate. So if you stop taking folate, if you're deficient in folate, your reserves are going to run out earlier. Whereas cobalamin, the ratio is much higher. So because of that, you're going to present later. And what happens initially, it is going to be an increase in MCH and MCV, and it's not going to be straight away fall in hemoglobin. So many times patients who come with a little tiredness, not feeling well, hemoglobin may still be in the normal range. It may still be reported as 11.5 or 12, but your MCV is 95 or 100. So then in pediatrics, even 95 would be taken as significant. So if there is an increase of even 3 to 4 units, high increase in MCV, even without a fall in hemoglobin, one has to rule out early megaloblastic anemia. So what happens in nutritional, so this is a picture, again, very beautiful reviews are there, which tell you all aspects of vitamin B12 and folate absorption. Just few points so that we can discuss the rest of it easier. So here, when you take in folic acid and B12, it is bound to transcobalamin 1. And this folic acid comes down. So it's a yellow dot, which is coming down and it's getting absorbed from the proximal small intestine. So why is it important to us? Any child with a celiac disease, anybody having any gut surgery, children who are presenting with any proximal gut involvement, these patients are going to have folic acid malabsorption. That is one thing which we should be aware of. Next, if you look at the B12, so the B12, once it comes down bound to transcobalamin, it is going to get attached to intrinsic factor. So why is it called intrinsic? Because earlier when pernicious anemia was described, extrinsic factor was the B12 that we ingested, and intrinsic factor was what the body had. So these two combined together form this complex and went further down to the terminal ileum for absorption. So it is going to go down. So here again, if you have any gastric bypass surgeries, that would be significant from an malabsorption point of view for B12. And of course, terminal ileal issues. So terminal ileum, if there is inflammatory bowel disease, tropical flu, all these conditions can result. And in pediatrics, again, Hirschsprung disease, children who are getting operated, large gut resections, they definitely will have this. They may have multiple, anemia could be because of multiple issues. There could be anastomotic ulcers, bleeding, iron deficiency could be because of that as well. But B12 is something we should be looking into for these large gut resection children patients as well. And it's absorbed through this receptor called tubulin. We'll see how tubulin is important in a while. So this is the simplest way it can be explained. It's a very, very complex absorptive pathway. And again, the metabolism of it, cobalamin is needed only for 2 steps in the body. And cobalamin and folic acid is part of what we call the folate trap. Again, very simple way of explaining would be that there are these 1 carbon donors in the body. So 1 carbon donors are required for synthesis of purines and pyrimidines. So you have all our folate is in the form of tetrahydrofolic acid or tetrahydrofolates, and it could be either formyl, it could be methinyl or methylene tetrahydrofolate. So in all these steps, it could go front or back. So it could be either ways. But from methylene tetrahydrofolate to methyl tetrafolate, it's a unidirectional reaction. And from there, when it gets converted into tetrahydrofolic acid, so that again is a unidirectional reaction. So for this reaction from methyl tetrahydrofolate to tetrahydrofolic acid, you would need cobalamin. So cobalamin takes on this methyl group to form methyl cobalamin. So that is important here. And once this is formed, you cannot go back. You cannot go back. So that is why it is called a trap. Because if you have cobalamin deficiency also, the folic acid is, even though it is available in the body, it is still trapped. So that is why we tell that in cobalamin deficiency, if you give folic acid in excess, or if you give only folic acid, it is going to actually worsen the cobalamin stores and worsen the neurological presentation. So this happens. So when cobalamin deficiency happens, you have again, it is methyl cobalamin is there, and methyl cobalamin is not able to, this conversion is not happening back, and that is why homocysteine increases. And again, these S-adenosyl methionine and S-adenosyl homocysteine, these are important for neurotransmitter generation. So they again there is an imbalance here as well. So that is why we have defects in, so homocysteine increases, thrombosis, tetrahydrofolic acid is trapped, because of which you don't have any nuclear maturation does not happen further. So that is the reason for all that megaloblastic part of it and the ineffective erythropoiesis part of it. And because of this SAH imbalance, this causes the neurological other manifestations like psychosis, etc. So this is a very, very simplistic way of explaining how this all happens. Now, when we see the bone marrow, what happens? So there are these megaloblasts. So this peripheral smear shows these large cells. This is the large peripheral smear. We're showing that large macro ovalocytes which are seen in circulation. And then there are these large cells which are looking almost like blasts. So they are opened out chromatin. There are some of these, this will happen on all 3 cell lines. So it could be giant metamyelocytes as well. And when the metamyelocyte could be into giant band forms. And from the giant band forms, you have neutrophils, and neutrophils will be hypersegmented. So the nuclear maturation is getting delayed, whereas cytoplasm is perfectly normal in this case. And peripheral smear, so this finding of, other than macrocytes and macroovalocytes, finding of peripheral hypersegmented neutrophils is somehow, it can be taken as an ancillary thing to vitamin, even the assays as well. So if you get this kind of classical picture, you could go ahead with a therapeutic trial of B12 and folic acid. If you have to differentiate, then there are ways to differentiate it. But if there is only anemia, this is something that we can do. In due course, what happens is, because these cells are large and these cells start getting destroyed in the marrow per se. So it's similar to thalassemia. There is ineffective intramedullary cell death that's happening. And because of which the retic is not going to be as high. So you have severe anemia, you have jaundice, you have splenomegaly, but when you look at your retic count, it is not corroborating. So that is something which we see in megaloblastic anemia, similar to what we see in thalassemia. So what percentage of patients who have other cytopenias? Thrombocytopenia is very, very common. It usually is mild to moderate thrombocytopenia, but as the degree of megaloblastosis increases, it could be very, very severe as well. So very clearly, we've seen patients who come with 4,000, 5,000 platelets, adolescent children. When you think that this cannot be should be aplastic anemia, but then they beautifully respond. When you do a marrow, it's cellular, and when you treat them, the platelet count beautifully responds to treatment. Similarly, neutropenia, almost 25 to 50% of children will have neutropenia. Not very severe, but occasionally we do see ANCs less than 100 as well. Among children who present with pancytopenia per se, if you look at what percentage have megaloblastic anemia, that would be again around 25%. So in pediatric series, which has looked at pancytopenia, excluding leukemias, obvious leukemias, excluding either blasts in circulation or patients who have presented with other patients who are post-chemotherapy cytopenias. So if you remove all that and look at only pancytopenia as an initial presentation, out of that around 25% would have megaloblastic anemia. So that is about the hemat features. Now what happens, or why do neurological features happen? So what is happening in neurological features is, like we saw infantile tremor syndrome, it could be developmental delay, it could be spastic paraparesis as was classically described in the subacute combined degeneration. There could be extrapyramidal features like tremors, there could be seizures as well, there could be psychosis, and there could be ataxia. So even not just the posterior column related ataxia, even cerebellar ataxia has been described by many neurological case reports have mentioned it. And the infant of a CBL deficient mother, this is that earlier baby we saw who had tremor. This is few days into treatment. So usually they present with failure to thrive, developmental delay, some motor social retardation, tremors, and hyperpigmented skin. So this entity called infantile tremor syndrome was initially described in India. So the multiple reports which came out, and multiple reports which actually came out in Western publications before it came in Indian publications, that there are these groups of children, this mother baby dyad, who both of them are deficient, and they present very early with this clinical features. And this has been described, the treatment would not be just treating the baby, it would be treating the mother as well. And these are the neurological features. So if you look at the reason why the mother had, so this was a paper which looked at why the mother developed B12 deficiency in the first place. Did she have pernicious anemia? Was she vegan? Why? Because of which she became. So again, in both of these, it's almost comparable. Both of these, there are babies who are going to, the children born out of these mothers would have these features of both developmental delay, abnormal EEG, seizures, tremors, etc. So what happens in the neurological system is, one, there could be delayed myelination or there could be demyelination as well. So this demyelination is what is described in severe subacute combined degeneration. The delayed myelination is occurring because we have, we saw in that pathway, there is adenosylcobalamin, and which converts methyl malonyl CoA to succinyl CoA. So if this conversion is not adequate, there is excess of propionyl CoA which is formed, and that causes some altered fatty acids which are formed, like C15 and 17 fatty acids, and that gets incorporated into nerve sheath. So there is a dysmyelination that is happening in infants or newborn babies who are born to B12 deficient mothers. And similarly, in older age group, the ratio of SAM to SAH is impaired, and that again because of that folate trap we mentioned. So neurotransmitters are impaired, and that is the reason why the neurological manifestations happen in older age as well. Another manifestation we saw was hyperpigmentation. This again was initially described in Asian communities only. We see it very common. We see commonly in both B12 as well as folic acid deficiencies. And we see even in our post-chemo patients as well. So what happens here is that because of this, so this megaloblastosis is not just in the hematopoietic system, it could be there in all nucleated cells. So what happens in the case of skin is that because of this, there is a because of this defect in the because of this block, because of this folate trap, there is increased metabolites are diverted towards tyrosinase. And because tyrosinase is part of the melanin synthesis, then the tyrosinase related proteins get upregulated because the others are getting blocked. And here also cysteine is formed more, and because there is homocysteine, cysteine is also formed in more quantity, and both of them contribute to melanin. And there is decreased transfer from the melanocyte to a keratinocyte, and that also results in prolonged hyperpigmentation that is occurring. So it does not get shed off, it remains as such. Why thrombosis? homocysteine, of course, has been implicated and it's been there as an atherogenic factor. There is a lot of hype around homocysteine. Homocysteine can directly cause injury to the vascular endothelium. It could also affect the prothrombotic pathway as well. So a lot of mechanisms have been suggested for homocysteine. But there are homocysteine independent mechanisms also. So basically, it could cause either arterial or venous thrombosis. Both are known. But whether homocysteine lowering therapy per se in people can prevent the risk of stroke or venous thrombosis is controversial. So there is, even in Cochrane reviews, they do not have a clear answer on this part. So per se, doing it will not be helpful, but definitely if it is high, treating it would be helpful in reversing it. And other than neurological, the neural tube defects, which we all know, folic acid supplementation in the peri-pregnancy period would also help in preventing non-syndromic cleft lip with or without cleft palate, as well as in some congenital heart diseases also. And it's always peri-conceptional, because by the time you know you're pregnant, all this neurogenesis part would be over. So that is why we start in the when the family is planning a baby. So what are the causes of cobalamin and folate deficiency? We are all very, very well versed with the nutritional aspect of it. It could be either malnutrition per se, or somebody is very fussy eater or vegan, because of which you cannot take any proteins of animal origin. It could be a mother with CBL deficiency per se, or somebody who is excessively dependent on goat's milk, which is deficient in folic acid as well. Among malabsorption, from the picture, we know it's all upper part as well as lower part. So it could be gastric surgery, or if you are on drugs which inhibit gastric acid for a long time, like PPIs, or it could be bacterial overgrowth, tropical screw, Crohn's disease, parasites like Diphyllobothrium, etc. can cause malabsorption. And finally, in the metabolic part, there are genetic disorders which cause B12 deficiency because of defects in the metabolic pathway as well. What about folic acid? Folic acid is not that, we don't have so many reasons for folic acid deficiency. It's essentially only nutritional deficiency or increased need. So that's why we see it in preterm babies. We see it in the second half of infancy when babies are growing really well. And third would be in chronic hemolysis, pregnancy states, and lactation. These are states when the body requires more folic acid. Among malabsorption, here again, like we mentioned, the proximal small intestine, so either achlorhydria or celiac disease can be implicated in folate deficiency as well. And there are metabolic defects for folic acid as well. So there's a lot of discussion on why Indian diet is prone for megaloblastic anemia. So always the discussion usually is that the Indian diet, the food of animal origin is less. And even if there is an Indian non-vegetarian, the consumption of non-vegetarian, the meat, especially red meat, is less when you compare to an equivalent Caucasian. So that is the usual explanation. But other than that, there is also this explanation that it could be because of bacterial contamination. So it's all our food, all our B12 is not coming in from food of animal origin. Some percentage of it would be coming from bacterial contaminated food and water. So the more sanitized we become, the more developed we become as a society, the more cleaner water that we get, or the more sanitized food that we get, the possibilities are that your B12, the source of B12 is getting cut down there as well. So these are two reasons which have been suggested as to why we are seeing more and more of B12 deficiency. And like we discussed in the beginning, pernicious anemia is something which was which led to all this research. It was described very well in Western literature. In Indian literature, not so much, but there are case reports which even treated patients with liver extracts in India as well. And nowadays, you don't have the traditional gold standard Schilling test for diagnosis. You have anti-intrinsic factor antibody, which has a very good specificity and positive pressure, a positive value also, positive predictive value as well. So this is from a case report by Dr. Dasgupta from Calcutta. So this is looked at exactly how the liver was given for those patients treated by Murphy et al. Similarly, it used to be given in our country as well. Now there are secondary causes as well. So it could be related to drugs. So like we see in a lot of our cancer patients also, there could be hyperpigmentation, blackening around the eyes, which may be seen while the child is on methotrexate or 6-MP. So it could, all drugs which involve purine pyrimidine metabolism can cause this, and except Septran as well can cause this. reducing anything which reduces the absorption of folic acid, like alcohol, estrogens, tetracycline, anything which reduces absorption of B12 like INH, PPIs can also cause drug-induced megaloblastic anemia. And finally, a bit on genetic disorders. When do we suspect them? When we have refractory or recurrent episodes. When you think you have treated it, but you do not, the child comes back again with the same. Or if you have significant other system involvement, like neurological involvement, other systems are involved, then again, you need to look for genetic disorders. Here again, folate, lot of transport pathways are there, and many of these have been very well characterized, but these are very rare disorders. So ultimately, the underlying factor is that there is usually megaloblastic anemia with a neurological feature, and the neurological feature is usually seizures and developmental delay. It starts very early. In all these folate transport mechanism defects, the treatment is usually folinic acid. Folinic acid helps in the hematological part of it. It does not help in the neurological part. So that's why early diagnosis is important, because once you diagnose, once you have set in neurological damage has set in, then you won't be able to reverse that. And if you have severe MTHFR deficiency, you can even treat them with betaine, and betaine reduces homocysteine as well. So that is supposed to be helpful in this thing, because in this group of patients, there is no anemia as such. There is only neurological involvement that is seen. So similarly, there are cobalamin transport metabolism defects which are there. It could be either hereditary intrinsic factor deficiency like pernicious anemia, but that is autoimmune and this is hereditary. And then there is Imerslund-Grasbeck syndrome. Again, case reports are there from our country also, where you have megaloblastic anemia associated with proteinuria. And here the treatment would be, it's because of the cubum receptor defect in that gut. We saw cubum receptor, which causes absorption into the terminal ileum. So that defect is there. Parenteral B12 would be the treatment of choice. Then there are defects in absorption, transcobalamin deficiency, haptocorine deficiencies, which have been seen. And then there are inborn errors of cobalamin metabolism, like we were suspecting in our patient, where patients present with megaloblastic anemia, neurological involvement, and hyperhomocystinemia. So essentially, there are three groups of disorders which present with hyperhomocystinemia and homocystinuria. We'll come to that in a bit. I think we'll do that before. So this is these are the three groups. So it could be either you have CBS, your classical homocystinuria patients who are their cystathionine beta synthase deficiency. So these children actually don't present with much of megaloblastosis. So our patient actually fits into that. You have ectopia lentis, a patient who has presented with little bit of neurological involvement, mental retardation, and ectopia lentis. But then this usually does not present with much of B12 megaloblastosis as such. But in our patient, megaloblastic anemia is a very predominant feature. The other one which presents very similar to this is CB1C. And this deficiency presents again with early onset seizures, mental retardation, multiple episodes of pancytopenia, megaloblastic anemia. And in the eye, there could be features like pigmentary retinopathy, nystagmus and delay, decreased visual acuity. And third, if you have MTHFR defects like we saw earlier, that also can present predominantly with neurological involvement, but with homocystinuria without megaloblastic anemia. In our case, we went ahead and got a molecular testing done, but that was negative. It did not identify any pathogenic variants. Then we asked for the the coverage of those genes which looked at homocystinuria, and we found that the CBS was covered. The CBS coverage in these NGS platforms, the CBS coverage is actually very less. So we're now looking for a direct sequencing of the CBS gene as well. And finally, among the inborn errors, there are defects which are thiamine responsive. So there are autosomal recessive disorders where patients have megaloblastic anemia. Along with that, the same defect is there in the transporter defect is there in the pancreatic islet also. So they present with diabetes mellitus, and it is there in the inner ear also. So they present with hearing loss. So these are families which are usually consanguineous families, and they present with visual cardiac neurological features, and they respond very well to thiamine. And then there are hereditary orotic aciduria and some other rare disorders which can also present with cobalamin transport metabolism defects. So these are so nutrition, malabsorption, drug-induced, and finally genetic. And these are the reasons why we have megaloblastic anemia, and these were the presentations. Now, if you have, how do you go ahead and treat it? So first of all, we need to diagnose it. We need to also know whether it is whether it is B12 or folate or both. And do we really need to know that? We'll look into it. And we need to know why it is deficient so that we can treat them. So hematological, we already discussed. So these are the tests that we do. Is the bone marrow indicated in all? No. But definitely, if you are not getting a response, so something when you are starting off treatment without on a therapeutic trial, perhaps, or even if you are starting on a trial, starting on a treatment with a patient who has B12 levels low or folate levels low, always look for response on follow. But because many a times, even if a patient is having an underlying bone marrow condition, like a non-megaloblastic condition, there could be associated dietary deficiency as well. So many of times it could be combined. So if you may miss an aplastic anemia or a myeloid leukemia, if you just start treatment and don't follow them up closely. So the first few visits are to be very mandatorily looked into, and after that, probably the responses is there. You can probably call them after a month or so. The other investigations which are available are vitamin levels. Vitamin levels are, you can do assays of B12 folic acid, but there is still no gold standard in this. There are a lot of inter-lab differences and age differences. So when you're interpreting it, if you're doing it, we should know how to interpret it. And finally, there are functional testing, which looks at metabolic biomarkers. We have MMA as well as homocysteine. We'll look into it in a bit. So this is a child where we burnt our fingers. The 14-year-old boy who came to us in 2017 with severe pallor, with some kind of some growth retardation. So there is weight and height, both are low, and no organomegaly, and there is past history of recurrent diarrhea. So we thought this is some kind of gut issue with a nutritional component. Hemoglobin was 5, MCV was 102, TLC low, platelets again 1.2 lakhs. Peripheral smear did show macrocytic cells as well as segmented, hypersegmented polymorphs. So on the basis of thought, a short child with all this, we thought it could be B12 or folic acid deficiency. We started on treatment for that. There was no neurological involvement in this child. And because of short stature and anemia, we did a TTG to rule out celiac, and the TTG came positive. So once it came positive, we got the gastro team to plan an upper GI so that we can go ahead with the diagnosis of celiac. But when it was scheduled, it was the same day when he had come for a follow-up. And when we looked at the CBC, there was no significant response to B12 or folate. So that is because with the upper GI, we ended up doing a marrow on the same day, and it was MDS AML. So these are conditions. So even if you have features like hypersegmented neutrophil, a child, everything else is fitting, a short stature, a child with nutritionally deficient child, but still it could be something underlying. So very, very close follow-up is required. And this child eventually went on to be diagnosed as GATA2 deficiency. So coming back to the diagnosis, vitamin B12 levels, you have cobalamin assay, you have holotranscobalamin assays. So these are the tests which are available freely to us nowadays. Cobalamin assay, the chemiluminescence based assays are ones which are very commonly available in many labs. And as we know, most labs have different values, different normal ranges. So something we should be aware of before we are testing. And again, a borderline low. So sometimes we could have patients who have borderline low values, but they are extreme normal. They could be patients who are severely deficient. Clinically, you have evidence of anemia and peripheral smear features, but your B12 level may come back as normal. So these things do exist. So we don't really rely very heavily on these tests for diagnosis. There could be falsely low values like in HIV. There could be falsely high values also. For example, in renal failure, a patient who has just started on treatment, these values change. HoloTC is a better test which is available to us. It's more reliable because it's looking at the active fraction, which is bound to transcobalamin 2. It constitutes only 10 to 30% of the plasma fraction, and a value less than 35 picomole defines deficiency. And this, when it's available, it's not very freely available, but if it is available, it can be used as an investigation of choice. What about folic acid? Serum folate, very freely available. We do not rely on it. There are normal serum folate is highly fluctuant based on what you ate that day, based on the age of the patient, higher levels in infancy. It is very highly sensitive, but its very specificity is quite poor. WHO defines a level of less than 4 nanogram per ml as folate deficient. If we have access to red cell folate assay, that is a better investigation. Why? Because it tells you what happened in the last 120 days of that red cell life. So that is a better reflection. But if you have been transfused or if you have hemolysis, etc., that again could have falsely high values because of the folate in the reticulocyte. Do we really need to know what is there? If there is a neurological involvement, definitely. And you would go ahead and get all these tests done, get the assays done if it is possible, or at least the functional testing done before we proceed with treatment. If it is not possible at all, then definitely start treatment for both. But if there is neurological involvement, even subtle, then you would start off with B12 initially and wait for around 10 to 14 days and then put folic acid. And many of these children would be iron deficient also. So once you start on treatment a week or 10 days later, many a times if you don't see that increase in hemoglobin happen further, then it would be worthwhile adding iron, because micronutrient deficiencies would be coexisting. What about functional testing? There is MMA, either serum or urine MMA, which is available, and plasma homocysteine, which is available. In B12 deficiency, MMA is increased, whereas folic acid, it would be normal, folic acid deficiency, and homocysteine would be elevated in both. So these are the BSH guidelines for using MMA and homocysteine for folic acid deficiency. And so if it is more than 750 nanograms, it would be B12. And if it's more than 15 micromole per liter, it would be folic acid deficiency. So 2 of our children had homocysteine in this case series. One was that thrombotic child, or the child who came with that arterial stroke, and the other one was this child with homocystinuria. So let's see what it comes out to be. And both of these, not just for diagnosis, we can use it for monitoring of treatment also. So usually we use only clinical monitoring plus lab hemoglobin pathological tests only. But if it is required, you can, if your response is poor, probably a functional look aspect can also be looked into. So whenever we manage, we reverse the deficiency, obviously, but reversal is easy actually. We just one dose can actually start reversing many of these things. But we need to find out why this happened. We need to decide what is the dose, what is the duration, what is the preparation that we want to use. And we need to ensure completeness of response before we stop the treatment, and always educate the family in order to prevent recurrences. So there are multiple ways of giving B12 and multiple ways people use it, multiple schedules that are out there. So there's no uniformity, at least in pediatric practice, there has been no uniformity till now. And currently the Indian Academy of Pediatrics is with the PHO chapter is bringing out a nutritional anemia guideline, which gives very clear guidelines as to what is the duration and the dose that is to be used. So it should be out in a couple of months. So the preparation that we use could be parenteral. There is IV, there is IM, there is sublingual and intranasal routes which are available for use. All of them have equivalent efficacy. Many people prefer starting parenteral, thinking that if there is a malabsorption, then it's better to start off with parenteral. But there are enough and more studies which have shown that oral testing is equivalent. Which is the agent that you use? So essentially we have three preparations. We have cyanocobalamin, we have hydroxycyanocobalamin, and when we have methicobal or mecobal, that which is available. So these are the preparations that are commonly available, of which mecobal is the one which is very cheap. Oral preparations are available. This is one of the preparations where isolated cobalamin is available. Otherwise, many of them have it in the form of multiple B complex, which is available together. The advantage of hydroxycobalamin is that it is longer acting, the retention is better, so your frequency of doses can be reduced, but there is some discussion as to whether it would induce an antibody to transcobalamin or not. It's essentially comparable, it's just a question of what we are used to. And then there is some discussion on whether which is better for a neurological feature. So there are some papers which would describe that if you have an active combination of mecobal and adenosylcobalamin, that would be the ideal preparation that we should use, because neurological manifestations would be, the recovery would be better if you give adenosylcobalamin directly. Oral route is as efficacious. There are multiple RCTs which show that oral route is efficacious. What is the dose that we use? The usual dose which we start in adults is 1 milligrams, and it's usually either parenterally if you give it either daily or alternate day, or it can be given orally as well. Whereas in pediatric practice, you could use a lower dose. In children, it could be 500 microgram, and in infants, it could be 250 microgram as well. And so there is no real again, there's no guidance to this, but there are papers which would have used around 30 microgram per kg per day, rounded off to the nearest tablet strength, which has been found to be efficacious. So this is the essential dose. If we use a higher dose, what is the advantage or disadvantage of it? Advantage is there is nothing really, since it is absorbed and it is stored, it probably your duration of treatment reduces if you use a higher dose. Other than that, there is no advantage at all. There is no guarantee of an earlier response. And in fact, if you use a higher dose, there can be tremors and extrapyramidal symptoms, which we saw in that baby. Those things, those tremors can actually worsen, and hypokalemia can also worsen when you use higher doses. So it's preferable to treat smaller children with smaller doses. The usual reversal happens in 6 to 8 weeks. So duration of treatment would be roughly around 3 months. In malabsorption or vegan, which are two scenarios where we know that they are going to be B12 deficient all throughout. So in these patients, they would require lifelong cobalamin treatment. To that, I would add that if they're coming from a family where you can't ensure this, then at least call them back and look for a deficiency if it is recurring again, because that is quite commonly seen. We do not monitor vitamin levels. We can look for response in biomarkers. In Western guidelines, what they initially do is they look for whether the intrinsic factor dependent pathway is intact or not. If it is not intact, then intramuscular injections are preferred. And usually there's a typing error. So it's 1 milligram of B12, which is given every other day for 1 to 2 weeks, followed by weekly injection for a month. And then it's tapered to once a month, and it's continued indefinitely. So this, even in intrinsic factor deficiency, there could be, if you give high dose oral B12, even then that could also be absorbed, and even sublingual intranasal forms are also available for these patients. Coming to folic acid, the usual prescribed dose is 1 milligram. So we always wonder why this 1 milligram dose comes up, because we know the RDA is quite low. So this is the strength which has been advised. Why the textbooks say that if you increase it, we are giving usually in the 5 milligram dose. So when you go up to 5 milligram, there are concerns that higher dose of folic acid can be toxic. And that is why still recommendations keep it as 1 milligram, although practically we do not have a 1 milligram preparation even now for using children. And even now we follow that 5 milligram, usually in thalassemia practice, at least it's less than 3 years, it's usually half a tablet is given. And after that, it's usually full 5 milligram is given. And even in malabsorption scenarios also, the oral tablet would work. Folinic acid is not required unless in those scenarios that we saw where there is an absorption defect because of a genetic cause. In those conditions, we would add folinic acid. And usually here again, stores would become replete in 1 to 3 months. So the usual duration of treatment is only up to 3 months, and continuation therapy only when we know that they require ongoing folate supplementation. Many countries are very, very wary of the fact that there could be folate toxicity. And that is why serial supplementation, etc., has not actually caught on in many countries, because they think that you are unnecessarily subjecting people to higher doses of folic acid, which is not required. There is also this worry whether it would unmask a cobalamin deficiency, whether it could reduce epilepsy control, whether it will cause seizures. And there is some paper from India which gets quoted everywhere saying that there is some increase in diarrhea or increase in pneumonia after you give folate. So that also gets reported quite frequently as an argument for reduced doses of folic acid. So once you start, we generally go by only clinical response. We look at ineffective erythropoiesis. So like in iron deficiency anemia, the first thing is the child is feeling better, appetite is better. And by day 2, day 3, your reticulocyte count response is there. The response starts. And this is the time by day 2, potassium would start falling if you are treating a severely megaloblastic kid. So that is when you look for it. Your glossitis starts healing, LDH comes down. In a week's time, NCV starts coming down. So if you're calling after like 1 week for a child who is mildly deficient and you're sending on OPD practice, that would be a good time to look at NCV. And if there is dimorphic anemia, we may not see this kind of a reduction immediately. So that is something which we look into. And by week 2, the hypersegmentation also starts improving. And that is one of the last things to improve, that hypersegmentation would remain till the neutrophil is around. And neurological and GI manifestation also start improving by week 2. And like we said, in the first 1 week, there could be worsening of neurological features that we should be aware of. We should be counseling the families as well. And usually indices normalize by 6 to 8 weeks. And if we do not get a response, the first thing is look for iron deficiency, because many a times it is there. Second is, like we saw in that case, it could be an incorrect diagnosis. So there is something which is additionally there other than what our usual nutritional component. Also, it could be an MDS. It could be something which is causing large cells. So MDS, it could be a myeloid leukemia. It could be other causes of macrocytic anemia, like a liver dysfunction, or even in many other conditions where macrocytosis can be seen. Or if you are started for B12, it could be folate deficiency. That could also be there. And slower response and neurological responses are usually take time, because by the time all these neurotransmitter imbalance is settled, only then this would happen. And especially if there is a myelination defect, those neurons are not going to recover, and that would take a very long time. Many a times developmental delay may not be immediately reversible. We always treat the mother. If you're treating a child of an infant and a small child who's breastfeeding a mother, definitely we would treat her as well. And that is usually deficiency in the mother may not be clinical, it may be subclinical, but treat them like we treat for a clinical deficiency. And finally, before I wind up, some observations which we found in practice. These are like part of a study where we'll probably see that if you treat an iron deficiency anemia and versus if you treat a megaloblastic anemia, the weight gain that you see immediately post-treatment is very, very high in megaloblastic anemia. I really don't know the answer to this, so I would request seniors in the group to give their comments. But like weight gain to the tune of 5 kilos, 10 kilos in 2 months to 3 months, that is something which we have observed. These are 2 children who have this response. So this is like within a period of a month, there is an increase of say 6 kilos. So these are conditions. So we have gone ahead and evaluated even thyroid function. A lot of endocrinological workup has also been done, but nothing really came up. It's just that it's as if the body was completely deficient of this one vitamin, and then when you got it, suddenly it started to grow. So it's almost like that, but it's an observation which is consistently coming up in practice where I work. And another is that there are ways now of we can actually, from the CBC itself, from the MCV and the platelet count, we can actually differentiate earlier on. So if you have a very pure low MCV, high platelet count scenario, it could be just iron deficiency. And if you have a very high MCV, low platelet, it could be just pure megaloblastic. But anything in between, it could actually combine iron and B12 deficiency. Traditionally, there is nothing which guides us in this practice. So this is a study we are currently conducting, which looks at the parameters and trying to derive a value which will tell us whether if this is the cutoff, then you probably should be dealing with both IDA as well as megaloblastic anemia. So I'll wind up here. The take-home messages is that it's a significant percentage of our anemia practice. It can mimic it could be many other diseases underlying as well. We need clear guidelines. We really don't have them. We are heavily dependent on Western textbooks even now. And once we start treatment, follow-up is vital for treatment. So this is a center that I work. It's a government institute in Noida. And I thank all my teachers, my colleagues, the nursing staff, my students, patients, and their families for all the work that was shown. And happy Independence Day to all of you. Thank you.
Thank you, Professor Nita, for that wonderful presentation. I think many of the listeners must have first time realized what is the scope of this particular subject and how wide it is. Superb. So before we go to the Q&A session, we'll give you a rest for 2-3 minutes, and we'll give the answer to the quiz for the postgraduate and others. I'll just share my screen. So today's quiz was related to Gaucher disease type 1. You were given 10 statements, and you were asked to pick up the false one. Gaucher disease, there are 3 types. The type 1 is the commonest, and that was one of the quiz. It accounts for 94% of the subjects, and this is the non-neuropathic type. It only involves the internal organs. The type 2 is extremely rare. It's fatal in early infancy, accounts for less than 1%. Now, what you see in pediatric practice is the type 3, 5%, affects the central nervous system and internal organs and progresses slowly. So, of course, type 1 can present in pediatric or adults. As an adult hematologist, most of us see the type 1 only. So, the type 1 causes organomegaly. Patient can come with massive splenomegaly and moderate hepatomegaly. There is an interesting observation that you can have a splenic space occupying lesion, the biopsy of which shows what is called gaucheroma. It's made up of all macrophages containing the lipid field with this particular lipid. So that is called gaucheroma, and it has been present even in patients who have been well treated. So it's a bit difficult to explain the pathogenesis. We have one boy just now who's got this, causing the big spleen. This disease leads to two problems besides organomegaly. One is marrow infiltration, leading to anemia, thrombocytopenia, and one is damaging the bone, leading to osteopenia, osteonecrosis, and fractures. So you can have organomegaly, you can have hematological manifestations, and you can have bone problems. So to recognize this disease, you have to simply understand the extent of it. On one side, you've got organomegaly, you've got anemia, you've got thrombocytopenia, and there are some other causes of bleeding and bruising, and then you've got bone pain and fracture. And if you've got type 2 and type 3, there is neurological involvement. So this is the whole gamut, type 1 to type 2 to type 3, type 2 being the worst, type 1 being the best. It will be asymptomatic, bone disease, visceral disease, and then the neurology starts. One of the quiz was related to Parkinsonism. The gene involved in both is identical, and there is a distinct increased incidence of Parkinsonism in patients of type 1 Gaucher disease. The gene is the GPA. It is located on chromosome 1, and it's the same gene which can have 500 and odd mutations, accounting for these three types, clinical types. This is a cartoon of Gaucher disease where the macrophage is showing the storage. And that is a cartoon of the electron microscopy, how this material is stored in the macrophages. And that's the real microscopic picture. What you see is what is called crumpled paper appearance, or this kind of needle-like appearance as against the human peak cells. So you've got Gaucher here all over. Managing the disease is enzyme replacement, or substrate reduction therapy, or the bone marrow transplantation. So when you don't have an access to the first two, then only the bone marrow transplantation, or in a patient who is not doing well. Enzyme replacement therapy is the best, and some patients who do not have intravenous access or some other difficulties, or prefer only oral therapy, then the substrate reduction therapy. And that's the enzyme replacement therapy, Cerezyme. This is the sort of summary of the whole thing. Lysosomal storage disease, deficiency of beta-glucocerebrosidase, accumulation of glucosylceramide. This happens in the macrophages, which are highest in the spleen, liver, and marrow. Diagnosis, you show the deficiency of beta-glucocerebrosidase, or you look into the mutation in the GBA1 gene. Radiology helps you. Type 1, the age of diagnosis median is 22 years. Prevalence is, it's very rare disease, but there are certain population like Ashkenazi Jews where it is extremely common. As it's a rare disease, it takes time to diagnose, and the median time to diagnosis has been 7 to 15 years. Neurological involvement is in type 2 and 3. Splenomegaly occurs in over 90%, hepatomegaly in over 60%, and bone disease in over 80%. Anemia, thrombocytopenia are common. There are various coagulation abnormalities described. It will be attributed to low platelet, hepatic dysfunction, and some other mechanisms. This is an inflammatory disease which leads to a lot of hypergammaglobulinemia. It can finally lead to MGUS. Not only MGUS, it can lead to even myeloma. And there is hyperferritinemia, which was the other quiz. Parkinsonism disease is an associate with it. And these patients have to be also followed up for occurrence of malignancy. Some patients may be okay with just non-systemic therapy. Others require systemic therapy, which is enzyme replacement therapy. And if that is not possible, substrate reduction therapy. So this is a summary slide of the whole Gaucher disease. The 10 statements that were given to you. Gaucher disease is the most common LSD, it is. Type 1 is the most common presentation, it is. Type 1 is non-neuropathic type, correct. It presents with liver, spleen, anemia, thrombocytopenia, bleeding tendency, bone disease, often in combination, is correct. I'll come to number 5. Patients have these inflammatory markers like hyperferritinemia. They can ultimately lead to monoclonal gammopathy, increase in NK and NK T cells, all correct. And there is a long-term risk of lymphoma and myeloma, correct. Treatment is IV enzyme replacement therapy or oral SRT, correct. Bone marrow transplantation has been largely superseded by these, and patient assistance program is available as rare disease support therapy, so you don't have to really rush to the BMT. Splenectomy should be avoided, and there is an association with GD and Parkinson's. So what was wrong was Gaucher cell is a pathognomonic finding in Gaucher disease. That was the wrong statement, and that was the answer expected. Any disease where there is a very high cell turnover can lead to large amount of material which macrophages then accumulate and lead to the pseudo-Gaucher cell. So Gaucher-like or pseudo-Gaucher cell can be seen in large number of conditions where there is a rapid turnover of cells, especially leukemia and thalassemia. One of the commonest disease that we see in adult practice is chronic myeloid leukemia, where the marrow shows Gaucher cell, in pediatric practice thalassemia, which shows Gaucher cell. So the answer expected was 4. This was a tough one. We got only 4 correct answers out of almost 35 that we received. Second, third, and fourth are listed here. We got them between 11:48 and 11:54. Brigadier Dr. Sanjeevan Sharma, Dr. David V, and Dr. Satish Kumar. So thank you very much for forwarding this correct answer. Congratulations. Second, third, and the fourth. And the fastest finger fast, the one which was a bit few minutes before the second one, is our speaker today, Dr. Nita Radhakrishnan. She forwarded the correct reply at 11:45 a.m. You all know her, so I don't have to mention this. Congratulations, and we will send you a little bit of token from MHG for your efforts. So yeah, congratulations to you, Dr. Nita, and then we go to the Q&A session. So we have a raised hand sign from Dr. Shailendra Prasad Verma. Go ahead.
Yes, sir. Good afternoon, and very nice and lucid presentation, Dr. Nita. I just wanted to mention one of the practical problems when patient comes with a single dose of vitamin B12 from outside, and diagnosing this entity becomes problematic because at that time B12 levels are not done outside, and when you do the B12 levels, it comes out very high. So sometimes it gives the impression that probably patient is having something else than vitamin B12 deficiency. And another clinical problem which we face is when patient has this injection for 3-4 days and then it is non-documented, and then we have a retic count which is going up to 10 or 15% along with anemia, persisting anemia, and then it gives a dilemma of somewhat like autoimmune hemolytic anemia. So these are the two entities which we also be careful and not miss it. And if patient is getting supplementation, probably to continue that along with whatever investigation we are going to do. My question is for pernicious anemia, how do you do the workup for these patients? Do you look for pernicious anemia in all patients for presenting with the megaloblastic B12 deficiency, or do you have any specific indications for that?
Sir, I wouldn't have to. As an IC only pediatric practicer, so we don't evaluate for pernicious anemia unless somebody is is very refractory to treatment, oral supplementation, and we have to go on to have parenteral dosing. Only then we are sending evaluation. Otherwise, we don't send. So in the beginning also I told that my practice is entirely pediatric. So I've generally till now I've never had to evaluate for pernicious anemia in practice. We've had quite a bit of patients who come with other causes like secondary malabsorption, but not pernicious anemia.
Mentioned about the neurological manifestations. So do you routinely work up for vitamin B12 deficiency in those patients also who have neurological problems but have a more or less normal hemoglobin and normal MCV? Because in adults, at least it has been mentioned that those patients who are coming with peripheral neuropathy or maybe SSCD like manifestations, even their MCV and hemoglobin is within normal limit, still there are chances that they can have B12 deficiency, which can be reversible.
Yes, sir, if they are referred, provided they are referred, because many a times we don't get to see those children. So if they are coming with even recurrent seizures. So this is something which we teach our pediatric colleagues, that if we keep telling that if they are coming with an unexplained cerebral palsy, so many of them get into that bracket of cerebral palsy when they are coming with early onset seizures or neurodevelopmental issues. So even the developmental clinic, we have told them that if you have any suspicion, if there is the slightest of pallor, please send, so that we look for something which is reversible, or at least you can prevent further damage by picking those children up.
Thank you. Thank you.
Thank you, Dr. Sharma. Thank you, Dr. Verma. And I'd just like to add a few things to your observations that you mentioned. So patients who have received B12 or folic acid outside, oral or injectable. And when I was working in the government hospital, even the hospital diet, which is much better than what the patients used to get at home, could make all the differences in the hematological manifestations. The things that persist in the periphasmian, which can give you a clue, is one is hypersegmented polymorph. They don't easily disappear. And in the red cell, the Howell-Jolly body and the capitrix, they don't disappear. Only thing is, for this, you have to yourself see the smear. Very often a technologist will not concentrate on this. When you do bone marrow, the megaloblasts disappear very rapidly. The giant myelocytes and the metamyelocytes don't disappear for quite some time. So that becomes very, very easy way to diagnose these peripheral smear in the bone marrow. We in such patients don't even order the B12 folic acid level because they've already received it, so it's not going to be of any help. Regarding the neurological manifestations that you mentioned, so I had done neurology residency, and the one thing my boss taught me, in neurology there are very, especially in those days, I'm talking of 1970, there are very few treatable diseases, and B12 deficiency is one of them. He said any patient who has got 1% evidence of peripheral neuropathy or posterior cord or lateral cord involvement or dementia, one thing not to miss is B12 deficiency. And he will order this left and right. And lastly, in adult practice, coming to us when a patient is referred to megaloblastic anemia, that becomes a tertiary reference. We do in-house intrinsic factor blocking antibody test for everybody. The test is pretty cheap. When you're doing it in a mass level, it doesn't cost hardly anything. And you do pick up, it's not very common, but in a year you pick up two, three patients. And the second big clue has been a patient who keeps coming back to you with megaloblastic anemia every 4 or 5 years. This interval is very, very important. You treat him, he's got stores now replenished for 4 or 5 years, and then after 4 or 5 years, he relapses because dietary B12 is not getting absorbed. If that is there, even if intrinsic factor blocking antibody is not very convincing, I take them as that there is a problem because there is no GI manifestation and they're likely to be pernicious. Keep them on just one injection of B12 even 3 times in a year, and that's enough to prevent the relapses.
Sir, can I ask a question regarding that race B12? So there are some patients who come to us with race B12, as in the children of doctors, or somebody who is anticipating something and looking for, just we haven't advised it, but then when you look into all these complete portfolios that labs give out, then the B12 level comes high. And nothing else. The child has no symptoms of anything, any other condition which would cause race B12. And the child would have received some supplements maybe a couple of months ago. So how long do you wait in your practice to, if the B12 is not coming down, then you would evaluate further?
So this is a very common problem because nowadays the standalone labs do B12 as a part of the package. Yes. So a lot of people walk in with that. If there is a supplement given to them by oral route, then I tell them to come back after 1 week. If it has been given by parental route, I ask them to come back after about a month. At the same time, we are conscious of the fact that if they've not received anything and their B12 levels are high, we should rule out a hematological malignancy. I mean, to me, only that part is important, and that's very important that we rule out that. If there is an indication, not get paranoid about it, but unexplained high B12 level is a marker. One has to be a little careful on that. I don't know about pediatric at all, but adults, this is important.
And ALPS also, like you discussed.
Oh yeah, sure. Yes. Sanjeevan Sharma.
Firstly, I would like to, compliment Dr. Nita, for bringing out this very elaborate topic so simply and succinctly. So, it was a very good review on and I learned a lot about pediatric B12 deficiencies today, because as we practice as adult physicians, we don't see as many kids with the B12 deficiency. So, firstly, a comment, and then I'll follow it with a question to you. I, as a physician, I do not think that in current era, especially in the population in which we treat, B12 deficiency anemia is treated or should be taken as a typically a nutritional anemia. When we say nutritional anemia, we are implying that the person's nutrition is poor. So somehow that we see a lot of these B12 deficiencies in our serving soldiers. And there are young, healthy serving soldiers who are eating 4,000 calories a day. So there is nothing wrong with their nutrition. In fact, so much so that we gave this as a thesis topic to one of our fellows in AFMC in 2013. And from 13 to 16 in 3 years, she documented around 45 cases of confirmed B12 deficiency anemia in serving young, healthy serving soldiers. 65% of them were so-called non-vegetarians. When they used to eat meat and everything. So this, very simplistic thing that people who don't take meat or people who are probably our take from that little study of 45 patients was that it has to do with the intestinal malabsorption, a transient phase of whether it was bacterial overgrowth or PPI overdosing. So my question is, in your pediatric practice, how many times have you actually noted the B12 deficiency anemias to be purely because of nutrition, where you have historically taken that the nutrition of the child was suffering? And my part two of the question, I think Dr. MBA sir has already very elaborately answered that. I wanted to ask how often or how frequently you order B12 levels. I think it is not important to order B12 levels. The moment you suspect, you have also mentioned in this slide that you start treating rather than asking for a B12 levels.
So thank you for that question, sir. So we look for, as in in the group of patients that we see, predominantly it's still nutritional only. It is still patients who do not have access to good quality food. Like sir mentioned, if we keep them indoors and treat them. So even if even our other group of patients, like malignant leukemia patients and all, when they go home, when the time they are in the hospital, they are enduring the first few months, they are all very well nutritionally very good. The minute you put them on maintenance and send them home, by the time they come back after a month or 2 weeks, they're almost non-recognizable. So they lose weight, they're suddenly looking dull. So that part definitely exists, that there is poverty and there is the quality of food that they eat is quite poor. And even in that, even in villages, there is so much of access to all this junk stuff, so that their appetite is less. So that per se, they keep eating all this stuff only. And so children, generally the good quality food is less. So that part is definitely there. But like you said, we also see patients who are middle class families or high income families still having B12 deficiency. So that part is there. So and so we wondered why. So we've had these discussions. So that's why I mentioned Dr. Jagdish Chandra in one of the slides, that we have had this discussion during the nutritional guidelines also as to why this is happening. So one of the explanations sir mentioned, and which is recorded, is that we have become more sanitary as a group. So the water content, the coliform counts are coming down. So maybe there is a percentage of B12 which would have come from that. And that is slowly coming down. And Indians who have migrated from here to UK or to US, there are studies on those population also, which shows that they have also, there is B12 deficiency in those group of patients also. So it could be a combination of things. It could be nutritional. It could be the quality of food rather than the quantity, which is suffering. And even in families who are predominantly non-vegetarian, in them probably there is some other aspect to this.
And a quick comment on your weight gain thing. So in this very small cohort of 45 patients, actually 20 of them had to be put in a low medical category, because in army we have to put them in a low medical category for obesity, so not for anemia. And then the answer that they gave was that ever since their B12 treatment was started, their appetite increased so much that actually for the last previous a year, maybe 2 years, they were hardly having an appetite. And just these 5 or 6 doses of B12 increased their appetite to such an extent that they started eating everything. So they went on to become overweight.
True, sir. Same observation.
Sanjeevan, one more cause of adult B12 deficiency, which was pointed out by Dr. Prakash Joshi, who is a gastroenterologist in Nashik, to me about 25 years ago. And then we asked a student to do a thesis and confirmed it almost, is gutka consumption.
Okay, sir.
I don't know whether you have noticed it or not, or in military gutka.
Actually, sir, we did not say, I'm sure, because these are not non-military issues, because anybody is free to do whatever. So, but I think in that study, we did not take this history.
I would
used
say,
to, the alcohol we very meticulously took, smoking we took, but we forgot to take the gutka as a in the questionnaire.
So adult B12 deficiency, vegetarian, alcohol, and gutka are on the top. Absolutely on the top. Of course, in pediatric, alcohol, gutka probably both are out. So they have to keep searching for the etiology. Dr. Ketan.
Thank you, ma'am, for teaching us a very wonderful lecture on B12 deficiency. My video visible, sir?
Yeah, you're visible, you're audible.
Yes, ma'am. Yes, sir. Thank you, sir. Ma'am, I wanted to know that in a patient with confirmed B12 deficiency and no identifiable cause, and we have given supplements for 3 to 6 months. Then after that, how frequently to give them supplements, whether we should give them or not, or if we should give them, then how frequently we should give them, and how frequently we should monitor them, ma'am.
Follow.
Yeah, follow.
Response to your oral supplementation has been good. Essentially, then you're not looking at a malabsorption or a secondary cause for it. So if your response in the initial 1 month or so, 1 week, 1 month response has been good, and your hemoglobin improves subsequently, then the treatment duration is around 12 weeks. And after that, you stop. Only that once you stop, like I mentioned, they could go back to the same scenario after a few months or maybe few years. So you kind of keep calling them once in a while for a hemoglobin. So that's something. So if the parent is educated enough, the parent probably can see themselves.
Okay.
But otherwise, you just ask for a hemoglobin after a year or so. I just ask for 1 hemoglobin after 1 year, just to test it and ask them to come back if it is less.
Okay. So, ma'am, 3 months, ma'am, supplements is good. 3 months supplements is good. Yeah, 3 months.
There's no guideline like that.
Yes, ma'am, there's no different.
What is going to come out is so that writing group, what finally it was decided was 12 weeks of supplementation.
12 weeks.
Nathan Oski and many other publications do mention up to reversal takes around 8 weeks.
Okay. Ma'am, one more question. Like a vegetarian mother, she has taken adequate B12 supplements. Now she has delivered child. The child is on exclusive and top feed. Okay, so does the child stand a chance of being a B12 deficient?
No.
If
mother is on supplements, the hepatic reserves would be good. So
yeah.
And the breast milk content also would be good. So
no, ma'am, no breastfeed, ma'am. Exclusive and top feed.
Top feed baby food will receive. No, then generally all formulas would be supplemented.
Yeah. So less chance of child
requirement. Just timely complementary feeding is what would be advised.
Okay.
Thank you. Dr. Krishnarao.
Thank you, sir. Just a comment. It was highlighted very well by the speaker about the hypercoagulable state. Nowadays, I do see patients who come with stroke, pulmonary embolism. Homocysteine is done as part of the prothrombotic workup. And then I do the B12 level, it's found very low. So it's something which is a reversible cause of a stroke or a pulmonary embolism, so which we should not forget. So that's much I've been seeing in practice. Maybe the other seniors can also share the idea. And the other question which I wanted to have already answered. I mean, Professor Agarwal has already answered. In adult practice, where there is no nutritional deficiency, I think we should be doing the intrinsic factor antibody and parietal cell antibody for all the patients so that we can advise them to have a lifelong B12 replacement. And also, I also found that, you should look for other autoimmune conditions associated with that, like a hypothyroidism or, other endocrinopathies. So maybe others can also throw light on that.
Yeah, you're absolutely right about the last comment. That pernicious anemia, one important clue is hypothyroidism. Second important clue is vitiligo.
Correct. Yeah.
Megaloblastic anemia with vitiligo, with hypothyroidism, it's pakka pernicious anemia.
And one more question, in textbooks or all the publications we read, nitrous oxide exposure for megaloblastic anemia. I have not seen, whether how it happens and when it happens. Can anybody share their views on that? So every publication you read, there is a topic on nitrous oxide exposure causing megaloblastic anemia.
Nitrous is being used as an anesthetic agent. Right? So there are doctors who work in operation, staff working in operation theaters are at risk. Patients who are borderline deficient who are going in receiving nitrous anesthesia, they are at risk of worsening of megaloblastic anemia. So basically, as anesthetic use.
Okay.
Thank you. Thank you. Dr. Radhika.
You muted, Dr. Radhika.
Thank you, ma'am. So you have beautifully delineated the different manifestations of megaloblastic anemia. So what factors determine the particular manifestation of B12 deficiency in a particular person, ma'am? Is it just the severity of the deficiency? Or do we have any other factors like genetic factors or the intestinal microbiome which determines the kind of manifestations? Because some people manifest in a severe way with multiple neurological, hematological. Some people, even with deficiency, probably they'll just end up with mild cytopenias. So is it just a severity of the B12 deficiency, or do we have other factors which determine the manifestation?
I feel the severity is directly proportional to the degree of deficiency, or the longer the duration of depletion is, the more severe the deficiency is, that would be manifesting as a severe manifesting. The children who are, or patients who are coming to us early, you would be picking them very early with even mild cytopenias or just an MCV increase. So that's one thing, the severity of deficiency. Whether there are any polymorphisms which actually increase anything, nothing really much in that category. If you have genetic disorder, it's a proper genetic disorder. The autosomal recessive states that we discussed, they are prone for that. They are prone for very severe disease also, but nothing else which would increase your susceptibility, if that's what you're asking.
Yes, ma'am.
I have encountered.
I have a second question also, ma'am. So we have in the market commercially available multiple B12 supplements which are available, which apart from the B12, they have other multi-nutrients also, including folic acid, probably in the range of 200 micrograms and all. So as you said, a hyper treatment of folic acid can like mask a B12 deficiency. So how safe are to use these supplements in an exclusive B12 deficiency where folic acid levels are normal? Do you recommend? Because we routinely use it, we don't even like bother what are the other nutrients available. So is it safe like to use?
If you have definitive evidence that this is only B12 deficiency, then there is no point, there is no reason to supplement folate. There are preparations which are available which have only B12 as the component.
Yes, ma'am.
So that can be used for that. But if you are not sure, and if you think it's just nutritional anemia, as in this manifestation is only anemia, there are no neurological features, then you could treat both. And if you have neurological features, but still you're not able to test for it, that happens sometimes with us because the family is not able to, even though the test is cheap, there may be families who cannot do it. Then you start with B12, wait for 2 weeks, and then supplement folic acid at that point.
But there's no harm in using those the combination supplements, right?
Avoid. As in any other combination, we generally don't prefer, right? So similarly, B12 separate, folic acid separate is easily available, and so that can be given.
Sure. Thank you, ma'am.
At least those who are presenting with neurology, you, as Dr. Nita said, must avoid folic acid. There is nothing lost in waiting for a while because it can divert away whatever little B12 was going to the brain. So there, at least you should totally avoid folic acid. Satish.
Thank you, sir. Thank you, Dr. Nita, for a lucid presentation and presenting multiple facets of a common problem. My question is regarding the management in infants and small children. Though you have run the slides in your presentation, I wanted to know, how do you treat, for example, you had a 9 or 11-month-old baby. How do you treat infants and small children? Though you mentioned that some guidelines are going to come, and what is the dose you give, what is the form, and which form of methylcobalamin you prefer, and how long do you treat, ma'am?
So if it's an infant, the usual dose is 250 micrograms, and that dose can be given orally or parenterally. So if it's a child who has come with that irritable tremor syndrome, there's that kind of infantile tremor syndrome, or the child has some kind of neurological feature, maybe not tremors, but a little dull child, all those patients we start parenterally only. And then you wait for a couple of days, then you see the response, and then if the child is taking well orally, no worsening of tremors, etc., then you kind of tell them to continue oral supplementations at home. The duration is the same. The duration of treatment would be around 6 to 8 weeks only. Mother will be treated along with it. And among parenteral preparations, it could be IV or IM. If it's a sick child kept admitted, then we prefer IV in usual cases, because why poke unnecessarily for an intramuscular? That's like any pediatric patient, we generally avoid IM as much as possible. And especially there is thrombocytopenia, so you don't want any IM related issues. So that's usually IV preparation that is used.
So IV daily do you give for 7 days or 5 days, and then make it weekly for 4 weeks, like how we treat in adults?
Yeah, IV
Sick
daily
children?
for a week is usually good, and then after that you can, by then the child would be taking orally and all, then you can switch to oral and continue. Is that severe deficiencies, just in the first 2 days, be a little careful about potassium, because these are children who are anyway hypotonic, little dull babies. So to catch hypokalemia might be difficult clinically. So we have to still monitor and find out.
Right. Thank you, Dr. Nitin. Sir, I had a question for you. Are you using this disintegrating preparations of B12, sir, which are kept on the tongue and they just disintegrate? Because in adults, oral, somehow I don't have faith. I also tell everyone to take IM injections once a month or once in 2 months at least. And you mentioned even once in 3 months workout. But there are a lot of these disintegrating preparations which have come in the market, which have been given twice weekly, which our neurologists are very fond of. Have you started using them, sir, in pernicious anemia?
I don't trust anything except injectable. Only thing is injectable frequency can be as low as the patient wants. It hardly matters. A lot of people, neurologists, prescribe injectable once a month. But you give it once in even 3 months, it's more than enough. And I don't think I will trust any oral preparation for a patient who has got pernicious anemia, or whose stomach has been resected, the ileum has been resected, who has got a major GI disease. It's a cheap, harmless, water-soluble vitamin, and you just want to give 3 times or 4 times in a year, patient would take it. And I think there's some pharmacology, pharma gimmicks in this business. So I don't know. I won't do that.
I agree, sir. Thank you, sir. Thank you.
So we can go to the audience. There are only just 2 questions there. One question is from Dr. Ali. You presented a case. So he's talking about case 3. Can we attribute severe anemia commonly to only nutritional anemia? It's said in severe anemia in setting of malnutrition, we better look for additional contributing cause of severe anemia.
We may, but then in that case, the child responded. So there was nothing really no other underlying cause for that. So that's why we did not look for it. But if a child is not responding, like we have seen, there have been patients who are having hemolytic anemia, like spherocytosis, etc., who have presented with an additional B12 or a folate deficiency. So those children, of course, if you are not getting improvement or the spleen is big, etc., we would evaluate further.
And Dr. Ali, severity of nutritional anemia, don't underestimate. Patients have come with 1 gram, 2 gram, and they've got severe nutritional anemia and nothing else. And the point of potassium that she brought out is very important. We saw one patient on day 5 of B12 therapy, potassium was 1 point something. So be extremely careful, somebody can succumb. Dr. Naresh Tayade has a question. Why usually in infantile age group, this presents after 6 months, and why more common with neurological manifestations?
So after 6 months is usually because the body is growing at that time. The second half of infancy, the growth is actually more than what you see in any other time of life. So that is why all these nutritional anemias exacerbate at that point of time. And why neurological is because by the time, so this is something which is there since, so this is an infant who was born to a mother who is probably deficient. And so this kind of, there is this myelination defects which have been started probably in utero. And that's why it's coming as a neurological. I wouldn't say it is predominantly neurological. There would be other hemat issues as well along with it. But unless there is a genetic disorder which causes only neurological, but most of these tremor syndrome babies have hemat issues also.
Thank you. Dr. Govind Patel, is there any bone marrow megaloblast percentage cutoff value for diagnosing megaloblastic anemia?
I am not aware, sir.
So, Dr. Govind, it's not the percentage, it is the degree of megaloblastosis. So what you find is in an early case, subtle changes of macronormoblastic changes start setting in. There may be no megaloblast at all. So you find that the nucleus has become like sieve, the cytoplasm has become more basophilic. So when you look at it, it's a macronormoblastic erythroid series. So from there to a severe megaloblast, but the change will be all over. So it's not number of cells. As you know that the precursors of erythroid series may just look like megaloblast, 1, 2, 3%. Those early cells just look like megaloblast, but that doesn't mean anything. And the last question lying here is Dr. Hitha. How common is genetic causes of vitamin B12 deficiency in clinical practice, like transcobalamin deficiency?
They are quite rare. Even textbook descriptions are like 30 patients, 50 patients. There is data from India. There are case reports which have looked at Imerslin Grasberg. There are case reports of TRMA, thiamine-responsive megaloblastic anemia, and many other homocystinuria related also. But then, of course, in practice, it would be a one-not patient. It's not common at all. These are all autosomal recessive disorders.
Right. I think that's the last question in the audience. And if there are no questions from the faculty here, extremely grateful, Dr. Nita, for covering this subject so beautifully and patiently answering all the questions, sparing your Sunday morning. That was very, very important educational exercise. We have MCure to give the official vote of thanks. Yogesh, over to you.
Thank you, sir.
Thank you, sir. Thank you very much for this lucid presentations by Dr. Nita Radhakrishnan, sir. And on behalf of MCure, I would like to thank Dr. M.B. Garwal, sir, Mumbai Hematology Group, and all the faculties who have taken their time out today for this scientific discussion. We also at MCure are committed to for this partnership with the doctors for patient care, and we have technological advanced products like NCCAR 1K, Hamsil, Emtrio, Sidnavir, and recently we have launched MDARA Redix Fludarabine. So looking forward to your support, and thank you very much, Dr. Amira Rosar, for this opportunity. Thank you, sir.
Bye-bye. Bye-bye to
Bye,
everyone.
sir. Thank you.
Thank you, Dr. Nita, especially, and thanks you.
Sir.
Bye.